I'd like to thank the ACC and Dr. O'Gara for the invitation for the press conference today. So the purpose of the transcatheter valve trial, the partner trial, for this presentation this year is to look at severe aortic stenosis in high-risk patients who are randomized either to transcatheter valve or open surgical valves after greater than or equal to 3 years. So the minimum follow-up was 3 years for these patients. We want to look at mortality and stroke and other clinical outcomes, clinical and procedural predictors of mortality, and valve performance by echocardiography. And the design of the study was roughly 699 patients who were categorized as high-risk surgical patients, and they were categorized into transfemoral and transapical arms. The transfemoral then were randomized, so roughly 244 patients in the transfemoral arm to 246 patients in the surgical arm. And then if the patients went into the transapical arm, it was 104 patients in the transapical arm versus the 103 patients in the surgical arm within that transapical arm of the study. The key endpoints were mortality, all-cause mortality at 1 year. This is clearly a 3-year follow-up. Cardiovascular mortality, rehospitalization, stroke, vascular bleeding events, functional class, symptom class by NYHA, and of course echocardiography measurements. So our conclusions at the end of, when you just kind of bird's eye view from the whole trial, at 3 years what we found was that there was absolutely no difference in all-cause mortality for transcatheter valve and surgical valves. The baseline predictors were different between the two for transcatheter and surgical valves. We did find that roughly 80% of all patients in both groups, TAVR and SAVR, had at least NYHA 1 or 2 classifications, so they all had symptom, or the majority of patients had symptom relief. At 3 years, what we did find is that although there was an uptick in stroke rate early in the first 30 days, at 3 years, stroke rates are exactly the same between transcatheter valve and surgical valves. In fact, it's slightly higher, non-significantly higher in surgical valve patients. So the conclusion at 3 years is that there was no late stroke hazard in transcatheter valves. When we looked at the echocardiographic analysis, one of the concerns has been whether the valve, if there would be structural heart deterioration. And what we're finding is at 3 years, there's no difference between TAVR and SAVR in hemodynamic performance between the two groups. And consequently, EF was improved in both groups, similarly as was LV mass regression. So the last component was paravalvular leaks that I'll comment on. And what we did find was that paravalvular leak was more common in the transcatheter valve even at 3 years, and that if you had even mild paravalvular leak, that there was going to be increased mortality at 3 years in addition to those patients that had moderate severe mitral regurgitation. Thank you very much.
Thanks, Vinod. Very helpful. Let's get started with Dr. Quinones. I'm sorry.
Am I allowed to have to wait to the end for questions?
Please, yeah, I just want to have a comment from Dr. Quinones, please.
So there's no question, TAVR is here to stay. I'm going to combine my comments not only with this very nice presentation, but also some of the data that we've been seeing from registries in Europe. And clearly, the valves are showing to be durable. The 3-year outcomes are superb compared to conventional AVR. We don't know 5, 6, 7, 8, 9, 10 years because those have to still await. So clearly, one of the questions here as we're moving forward is, and valve will get better, is finding the groups that are best targeted for this. And we're all seeing the bar coming down from the extreme high to the high risk, and now more newer trials with lower risk patients. So that's going to be happening over the next few years to define that. And on the other side of the fence, as we saw in some of the data presented yesterday from the German registry, is the very high risk. I think there's a time where people may be so high risk that we may be doing something futile with such an expensive therapy. And I think we have to also tune up that a little better. And hopefully we will find those criteria much better in the future. So those are just general comments about TAVI. The issue about the AI is really a phenomenally interesting issue because in the partner trial, mild AI, even mild AI has a higher mortality, but in the European registries, it hasn't quite panned out the same. So there's
Mike,
some
can you just define AI for the?
Oh, I'm sorry. You're right. This valve frequently have a little leak. So a leak in the valve could be mild, moderate, or severe. So in the partner trial, even a mild leak was associated with a higher risk of events over the follow-up time of periods, which in the registries are not panning out as well with the larger data in the European registry. So, and of course, a lot of people, maybe even some of you in the room and some of us here, may be walking around with mild leaks in our aortic valve and having no problems. So that still remains a mystery, as it was discussed earlier. It may just be a marker of something else that's going on with these patients. But clearly, these valves are here to stay, and I think we are entering a fascinating time of management of these patients, and we're going to see improvements, and defining selection is going to be one of the key things over the years to come.
Great, thank you very much. Questions, please? Thank you.
As she's coming to the microphone.